next common type of neonatal jaundice in breastfed infants is breast milk jaundice. There's about 3 questions that we're going to be targeting in this discussion. 1, what it is. Secondly, why does it happen? And thirdly, how do we manage it? So please make sure you do stay with me till the end so that you don't miss this. Breast milk jaundice affects about 2/3 of breastfed infants. It is the most common cause of prolonged unconjugated hyperbilirubinemia in healthy infants. It usually presents about day 5 of life or a week of life, and it can persist to about 8 weeks of life postnatally. You will be able to differentiate it from breastfeeding jaundice by the fact that on top of this patient being healthy, they are also gaining weight properly, and you will not get any history of feeding difficulties in this patient. Same as with breastfeeding jaundice, breast milk jaundice is a diagnosis of exclusion, meaning that you have to make sure this patient doesn't have any signs of sepsis or hemolysis or any other cause of jaundice clinically before you can label them as breast milk jaundice. It happens because of substances found in the breast milk called beta-glucuronidase. This beta-glucuronidase inhibits bilirubin conjugation, and if bilirubin cannot be conjugated, it means it also cannot be excreted, and therefore it accumulates in the intestines. And if it accumulates in the intestines, it then gets forced to go back to the liver through the enterohepatic circulation, meaning that both breast milk jaundice and breastfeeding jaundice, there's an increase in enterohepatic circulation through different pathophysiologies. So that is the pathophysiology of breast milk jaundice. If it gets prolonged to about more than 2 weeks before you can safely say it is breast milk jaundice, you might want to do a workup for a prolonged neonatal jaundice. You'll do things like your TSB and your direct bilirubin. You would want to do your TSH to exclude hypothyroidism as a cause. You would want to do your hemolytic workup, that is your FBCs, retic count, blood group, and Coombs, to exclude the acquired causes of hemolysis as a cause. You might also want to do things like your G6PD screen to exclude the hereditary causes of hemolysis. So those are some of bloods that you can do for a workup for a patient with prolonged neonatal jaundice. So how do we manage it? So this is a benign problem. Therefore, what you need is to reassure parents. There is no need to stop breastfeeding. Monitor weight gain, monitor hydration. This TSB rarely goes above phototherapy. So there's rarely a role for phototherapy up unless your TSB is above phototherapy line. If you want to prove that this is breast milk jaundice, the other thing you can do is to stop breastfeeding for about 24 to 48 hours. And if there's a significant drop in your TSB, then you would have proven that this was breast milk jaundice. So that's how you manage breast milk jaundice.